if it is feasible, you continue to operate if it is falls within your competency level. Otherwise, you refer it to a center or an individual where the procedure or the treatment is being rendered. Post-operatively, it is not possible for every patient to go for the follow-up to the same center where he has been operated. Hence, they all wish to come back to the same person where it's been diagnosed and you can do the follow-up. So this presentation is going to be more into the early diagnosis, what investigations we have to advise, and once it is done, what precautions have to be taken post-operatively and including the rehabilitation. So can I share my screen? Yeah. Share. Can you share the screen, Prachi?
Yes, sir.
You disabled my screen sharing. Can you please enable that?
Yes, sir.
Sorry. Yeah. Is it visible to you? Hello?
Yes, sir. Yes, sir. You are visible to us.
And audible as well?
Yes, audible as well.
All right. Oral cancer diagnosis and current trends in management. Next slide, please. Yeah. Now, we're all into the oral cavity. We are not only dentists, we take care of the health of the oral cavity in general. So what are the subsides of the oral cavity? It starts from the lip, the tongue, anterior 2/3 of the tongue, the posterior 1/3 falls into the oropharynx. So, and the floor of the mouth, gingiva, upper and lower gingiva, buccal mucosa, retromolar trigone, and hard palate. These are the subsides of the oral cavity. So the malignancies can occur in any of these subsides. They all fall under oral cancers. In general, in the Western countries, only one subside is usually involved. But what happens in the Indian scenario is more than one subside gets involved. Because this is because of the habit of keeping the quid in the mouth, just below the lip or in the retromolar trigone or below the tongue. So more than one subside gets involved. Hence, it is known as the cancers, oral cancers, that what we see in Indian scenario is known as Indian cancer, because in general, more than one subside gets involved. For example, the gingiva, buccal mucosa, and the mandible, or the tongue, floor, mouth, and the lingual gingiva. So it is known as Indian cancer. Now, before we really go ahead, we should also know what are the different functions of the oral cavity. It provides the oral competence so that the lip becomes competent so that you can swallow, chew food and swallow. Lubrication because of the salivation. Mastication is the most important thing in the entire digestive tract area because you chew well. Speech, and again the swallowing. So you have to remember all these things because in the management of oral cancer, it is not only the resection that is important, the reconstruction and rehabilitation is equally important. We'll learn more about that as we go ahead. Now, what are the risk factors? All of us know the major risk factor is going to be the tobacco, along with the alcohol. Now, of late, it is because of the human papillomavirus. Males are more prone in general because of the habits. And in certain parts of the country, females, especially in the polar areas, of Karnataka, where females are also more prone to develop these oral cancers. Other etiological factors are poor oral hygiene, irritation from the denture, poor ill-fitting dentures, pre-malignant lesions, certain immunodeficiencies, and other occupational hazards. Now, what are the signs and symptoms that are involved? All of us know it's any red or white patch that doesn't vanish in 15 to 20 days or a month should be considered as pre-malignant or malignant. Non-healing ulcer, more than 15 days, progressive swelling or enlargement of the oral cavity or the adjoining structures, unusual surface changes. Normally the mucosa is pink and smooth. Any changes in that should be looked into as malignant. And sudden mobility of the tooth without any apparent cause. Bleeding and other epistaxis, prolonged hoarseness, that is mainly because of the tongue and the vocal cords getting involved. At a later stage, what happens is the patient can develop trismus. Trismus can also be due to oral submucous fibrosis, which is much more prevalent in India. And the swelling in the neck areas, that is known as cervical lymphadenopathy, apart from the other symptoms. Now, here comes patient's perspective. All of us should know the basic evaluation of a malignant or any swelling in the oral cavity and the neck area. Now, how do we evaluate? It is divided into 3 areas. One is clinical, radiological, and the pathological. The clinical area is divided again into 2 areas. Primary, that is in the oral cavity, and the neck areas. That is palpation of the lymph nodes of the neck areas. Now we go ahead with that. Clinically, history is extremely important to be taken. It's always been taught for us, and there is no question that you can skip that in the evaluation. Examination, that is a visual examination, and the inspection, palpation. In the palpation, site, size, edges of the ulcer or the swelling has to be palpated. To check whether all edges and or sides can be palpated. Sometimes it is not feasible where it is extending beyond the anterior 2/3 of the tongue into the base tongue, or in the maxillary region it is extending into the infratemporal fossa. So these are the areas which we cannot palpate. And you should also check the involvement of adjoining structures like skin, bone, or muscle. Now, radiologically, what investigations should the clinician advise? OPG, as we all know, we are very well versed with that. CT scans and MRIs. Now, when do you advise CT scan? CT scans are advised to check the involvement of bone along with the adjacent tumor. Now, what CT scan to be advised? It is CT-PNS, that is paranasal sinus, with contrast, and ask the patient to puff the cheek. When I say puff the cheek, am I visible to you also?
Yes, sir, you are visible.
Now you have to ask the patient to purse the lips and puff like this so that the cheeks go away. And that's how any malignancies involving the buccal mucosa or the gingivobuccal sulcus is being taken away from the bone, as it is shown in this CT scan picture. Can you see it over here? Yeah.
Yes,
so,
sir.
and then we'll come to know the involvement of the radiologist can comment on the involvement of the adjoining mandible or the maxillary alveolus. So this is how you should also know when to advise what. So if you are having a buccal mucosa, any oral malignancies, when you are writing the prescription, please ask them to take CT-PNS with contrast and puffed cheek. Now, when should you advise MRI? MRI gives a very clear picture or extension about into the soft tissues. Any tongue or floor mouth lesions, to check the involvement of or the depth or the extent of the tumor, MRI with contrast has to be advised. As in this case, you can see the white patch over there, which is taken up with the contrast, the depth of the tongue lesion over here, and on the other side, there is a anterior-posterior extent of the lesion can be visualized. So make it sure, depending on the site of the primary tumor, you should advise either the CT scan with contrast or MRI with contrast. CT scan will make clear whether the bony involvement is there or not. Okay. Then once the radiology, clinical examination radiology is done, we move on to the pathology. Now, what are the pathological options that we have? FNAC, that is fine needle aspiration cytology. This is usually employed for an inaccessible areas or deeper tumors where you cannot take a biopsy or where you cannot access. Sometimes the mouth opening is less, or in the neck node, which is deeper situated, you don't want to go and take a biopsy, which is not advisable sometimes. So in those cases, FNAC should be advised. Usually a pathologist will do that either directly or with the help of ultrasound or a CT scan guided FNAC can be done. Now, what as a clinician you can do is a biopsy. Biopsy can be either incisional or punch or excisional. Most of the times in the dental settings or in the OPD settings, incisional or the punch biopsies are advised. A 15 number blade, BP blade can be used, or a punch forceps can be used. And the biopsy has to be taken from the edge of the lesion, including the adjacent normal tissue. Now, try and avoid taking the biopsy from the central where the necrotic area will be high and you may not yield any tumor cells in that. It should be deep enough, especially in the verrucous carcinomas where it is cauliflower-like growth. What we expect is, what we do is we take a good chunk, but that all chunk is above the surface of the mucosa. We don't go into the depth. So pathologists will not be able to comment on that. And so hence the tissue should be deep enough. And once it is taken, take a good chunk so that the pathologist can comment well on the tissue. And it should be sent in a container with 10% formalin. Mention all the relevant clinical details along with the specimen. Nowadays, with the mobile coming in handy with everyone, you can also take picture of the site, the primary, and then you can share that with the pathologist. And occasionally, immunohistochemistry will be employed by the pathologist in case they are unable to diagnose it primarily on the regular histopathology, staining and evaluation. Let's not go into that. So once it is done, you have done the clinical examination, you have done the radiological examination, you have done the pathological examination. Once the reports are histopathology reports are ready, then it has to be staged. Now, I'm not going to really go into the details of NCCN staging. That is primary. It is named as PNM staging as well. When I say P, it is primary tumor. When I say N, it is lymphatic involvement. And when I say M, it is distant metastasis. So this is how it goes, TNM staging. So then we stage 1, 2, 3. Let's not go into details of those. This is only for the sake of treatment planning. Now, you should also understand the precancerous lesions and the field cancerization. In this case, you can see the primary is being removed is in the mandible over there, but the adjoining areas are also undergone some pre-malignant changes or the field cancerization. You can see red and white patches. Now, these all changes would have occurred. So these are the reasons for the recurrences. Sometimes they come back very fast because all this would have undergone some changes at the cellular level. Although the primary would have been presented only here, later on at a later stage, these can also undergo malignant changes and the tumor can come back. Now, that is how the recurrence, what is the recurrence and what is second primary? When I say recurrence, after treating the primary, if the tumor comes back within 2 centimeters of the first tumor and within 2 years of the primary treatment, then it is known as recurrence. Otherwise, it is known as a second primary tumor. That means if it is come beyond that 2 centimeters, or if it is come after 2 years of the primary treatment, then it is known as a second primary tumor. Now, let's go into the management. As we all know, the management of malignancies is multimodality: surgery, radiation, and chemotherapy. In head and neck cancers or the oral cancers, the treatment is going to be more of surgery and radiation, and chemotherapy is added as either neoadjuvant or adjuvant. We'll go into that details little later. Now, management. Surgery is the mainstay for the oral cancers. In the early stages, T1 and T2 stages, surgery is going to be more than any other areas, or radiation is not necessary, but that is decided by the final histopathology report. Now, when it comes to surgery, what are the steps or the management? Now, there is a primary tumor which is raised in the oral cavity, so we'll have to remove that. Now, and then there is a chance that it can spread into the neck nodes through the lymphatics. So neck dissection has to be done. Once these two are done, it completes the removal of the cancer, and then a defect is created. Now that defect has to be reconstructed. Now, does it end here? No, that doesn't end here. After the reconstruction, the patient has to be rehabilitated. Now, what are the rehabilitation? Because the oral cavity functions are so many that we normally neglect during our day-to-day life. It is important to rehabilitate the speech, the swallowing, and the dental, where most of us come into the picture. Now, surgery. Now, why this plan is TNM staging, and the planning of the surgery is done in this way. Now, there is all the malignancies start with the primary cell. It multiplies and it increases in size, and it gradually increases to involve the adjoining structures. This is where it is important to diagnose at an early stage when the primary tumor is small, so that the management becomes easier, the surgeries become smaller, the results are better, and the prognosis are better. Now, if it increases in size, it can get involved in the adjoining structures like bone, skin, or any other nerve or muscle. Now, beyond that, it also spreads into the neck through the lymphatics. That is when what we know as involvement of the neck nodes. So that also increases in size. Multiple levels of neck nodes can get involved, and it can also involve the adjoining structures like carotid and other nerves. Now, after this, it can go to the distant metastasis like lungs or liver or anywhere else. Now, you should know it normally follows this pattern. Now, we go from the treatment from the other side. Whenever there is a distant metastasis, it has to be ruled out with a chest scan, ultrasound abdomen, or the PET scan. If the distant metastases are present, very clear that management of this patient is going to be more on palliation. So there is no curative treatment planned for this whenever there is a distant metastasis. Now we go one step further ahead or back. Neck node management. So what is neck dissection? It is the removal or the extirpation of the nodes and other lymphatic structures from level 1 to 5. And if it is seen involving other structures like internal jugular vein, spinal accessory nerve, sternocleidomastoid muscle, any other things other than the common carotid or internal carotid, they also can be sacrificed. Now, what are the levels of the neck nodes and why this pattern? That red spot shows the primary tumor. Normally, it follows a pattern. That is, from there, it goes and involves the level 1A, 1B, that is 1B, 1A, 1B is submental and submandibular. From there, it goes to level 2, that is the jugulo-digastric group of lymph nodes. And from there, this is the upper level, jugular digastric group of lymph nodes, and then goes to the level 3, that is known as jugulo-omohyoid, because this is the muscle, omohyoid muscle over here. This follows the jugulo-digastric, and from there it goes to the supraclavicular group of lymph nodes, that is known as level 4, and then again from there to the level 5 group of lymph nodes, that is posterior cervical nodes. This is the normal pattern. So if it is, but there is an exception occasionally. In case of tongue cancers and the floor mouth cancers, because of the abundance of the lymphatics, it can skip level 1 and 2, can go directly to level 3 and 4. So taking into this consideration, am I audible? Yeah.
Yes, sir.
So
Yes, sir.
in this case, the neck dissection, depending on the nodes involved, level 1, 2, 3 is the minimal resection to be done. And in case of level tongue and floor mouth, and depending on the involvement, level 4 and 5 can be added. This picture shows in the clinical picture, all the normal structures after the extirpation of the lymphatics, that is submandibular node has been removed over here, level 2, that is spinal accessory preserved, IJV preserved, all the IJV branches are preserved, the facial vessels are preserved, and from here it is level 3, and below that, this is the omohyoid, below that is level 4 and posterior cervical. So neck node management is equally important. Now we move on to the management of the primary. Now, in general, what is management of the primary is excision of the primary tumor with 1 to 1.5 centimeters of the margin. All structures in that 1 to 1.5 centimeters should be excised to get a clear margins. Now, what do you mean by clear margins? This is a histological slide from the pathologist, which shows with a normal mucosa excise, it is put to the formalin and then it is taken sections. If the margins are away from the tumor by more than 5 millimeters, it is known as clear margin. In this case, in the side, it is shown that if the margins are less than 5 millimeters, yet clear, it is known as close margin. If the margins of the resection there is a breach in the continuity and the margins are positive margins are there, it means we have left behind some amount of tumor there. It could be microscopic or it could be macroscopic. Now, what is the importance of clear margin? Whenever there is a clear margin, 77% survival rate is there, and then overall survival rate is 86%. And in the long term, 5-year local control rate, 91% of the margins, clear margins will have a local control. In the closed margins, 80.45% of the people will have local control. And look at this here, it almost reduces to less than 40% in case if it is positive margin, that is involved margin. That is why getting a clear margin in the primary is extremely important. Now, going to the primary management. Here, I am going to go simultaneously because of the oral cavity. It is not possible to think in nowadays. These are the recent trends. That is the other part of this presentation. Whenever there is a primary resection, you are going to create a defect. Now, you have to reconstruct as far as possible to the nearest normal all the defects that are being presented after the resection of the primary. Now, what are the defects that we'll go through? Mandible, maxillas, tongue, floor, mouth, buccal mucosa, lip, skin, and combination of any of these. Now, it can be a bone defect. It can be soft tissue defect. When I say soft tissue defect, it's going to be the mucosal lining or skin cover alone, or it's going to be the full thickness or combination of the mucosa and bone, combination of the mucosa, skin and bone. That is known as complex. So we'll go through each one of them. Now, one has to be clear what are the aims and objectives of the reconstruction. You have to have a clear thought, and you have to bridge the gap because patient's expectation is high. If the patient has come with a bulky tumor, big tumor, where it is going to be involving the both maxilla, mandible, and maybe the skin, and he expects everything to be reconstructed, it is sometimes humanly impossible to reconstruct. So you have to be clear about what is the patient's expectations and the delivering results. Now, what are the reconstruction goals? You have to try and match the suitable color, compatible thickness. If the mucosa is buccal mucosa is taken away, you cannot add a very bulky flap there. And retention of the primary, as long as possible, restore the sensory innervations. And it should be sufficient laxity so that it doesn't develop, the patient doesn't develop the trismus. And then the defect has to be closed well. Now, this is the reconstruction ladder. Earlier, we used to leave the wound to heal raw, but that used to lead to raw trismus and fibrosis. And gradually, we moved on to the pedicle flaps. And nowadays, since last 10, 15 years, the big step that has been taken over and the big advancement that has taken in the head and neck malignancies or oral cancers is the free microvascular flap reconstruction. We'll go through that once by. So that is the recent trend. And we have been practicing since last 15 years. Now, just to show, this is a lady without the mandible being reconstructed. Look at the defect and look at the confidence level also. It goes down. And these people cannot have a good quality of life. Why it is important to reconstruct is for the appearance, they will have to get back to their normal speech, chewing and swallowing. Otherwise, it is a compromised quality of life. So whenever it is possible, try and reconstruct so that they can go back into the society, live on their own, earn their livelihood, and support their family as long as they live. Now, the timing of the reconstruction. It is always nowadays done as a primary. It is always better done at the time of the removal of the primary tumor. Secondary reconstruction can also be done where it is the facilities are not there, patient comes at a later date. It can be at a
monthly.
What is the flap? Is any tissue? Achi, can you ask the participants to mute their...
I request all the participants to please mute their audios. They are having disturbances with the lecture. Yeah, humble request for everybody to see that your audios are muted at all times during the presentation.
Yeah,
so
we'll have
continue, please.
Open them for the question sessions. Thank you. Can I continue? Yeah. Now, what is a flap? It is any tissue with its own blood supply. Now, what are different types of flaps is one is pedicled, that is attached to the donor site for its blood supply and moved to the defect area. For example, it is a pectoralis major or the temporalis or the nasolabial flap. They can be local or regional. Now, what is a free flap? Fine. Now, a free flap is made up of skin, bone, muscle, nerve, along with its own blood supply, that is artery and vein, as a complex and compound tissue harvested together. Now, this can depend on the need of the primary defect. If it is only the surface, it's going to be only fasciocutaneous. If it is, it can be musculocutaneous. It can be musculo-osteocutaneous if the bone is involved along with the soft tissue. Here is the example of a fibula. We have two bones in the lower limb. One is tibia, that is weight bearing. Non-weight bearing or the supporting is the fibula. So in this case, it is being harvested along with the skin paddle. This can replace the bone and the skin can replace the soft tissue defects. And it is harvested along with the peroneal artery and vein. Same way, depending on the requirement, a radial forearm or an anterolateral thigh or a rectus abdominis, or for the bony defect, the iliac crest or the scapula can be harvested. Now, why do we need a free flap? Reconstruction of more than 5 centimeters defect support the adjacent structures like eyes, to replace the lost joints and the bone for the better aesthetic outcome by replicating the preoperative bone dimensions. Now, I'll show you one of the cases where all the three structures are involved. Now, this is the fibula being harvested. You can see the skin, you can see the bone, and there will be part of the muscle to maintain the vascularity to that bone. Now, along with that, the peroneal vessels, artery and vein are also being harvested. Now, once we harvest that without injuring, we detach it from the blood supply, that is from above here. This entire piece is taken and we'll shape the bone according to the defect, or if it is only the soft tissue, we'll shape it according to the defect, and that is flap is insert. Fine, this is the way it is being harvested, the fibula along with the skin, and that is the bone, and these are the blood vessels on over here. Visible? Yeah. Now, once it is done, this vascular, can you see the vascular pedicle still being maintained? So this keeps on the blood supply intact and keeps it alive. Now, once it is done, we keeping the blood supply intact, we shape this bone or the soft tissue depending on the primary defect. And if it is bone, we fix it with the titanium plates and screws. And then it is detached from this blood supply and the entire thing is carried. And this is bone is, or the soft tissue is fixed wherever the defect is there, and then reconstructed, and the anastomosis is done. We'll go through that. Now, this is one of the case where it's a big defect, maxilla, part of the mandible, and along with the skin. And it is reconstructed with either the rectus abdominis or the anterolateral thigh flap. This is the way rectus abdominis flap is harvested, depending on the inferior epigastric artery and veins. We'll go through, don't have to really go through that. This is one, although this is not a oral cavity defect, but for the sake of completion, I'm showing this is one of the skin tumors, squamous cell carcinomas, where the entire midface skin is excised, and then it is reconstructed from because only the skin and the fat is taken along with the artery and the vein over here. Is it visible over here? And then it is flap, the skin is sutured over here and the blood vessels are joined in the neck. We'll go through the proper oral cavity here. This is malignancy of the buccal mucosa. And simultaneously, I'll be showing you the different approaches used. This is a lip split and the cheek flap being raised. And the buccal mucosa is being excised with a 1 centimeter, more than 1 centimeter margin. Along with that, the alveolus on the gingiva is also coming in the way. So what we did is marginal mandibulectomy and the upper alveolectomy. So this is the specimen that is being shown. So that's what I mentioned earlier, that whatever falls in that 1 to 1.5 centimeters has to be excised. So this is the specimen after the excision. Entire buccal mucosa, upper alveolus along with the teeth, and the lower alveolus along with the teeth. This is also known as marginal mandibulectomy. Now, how it is being reconstructed? We harvest the radial forearm along with the radial artery and the cephalic vein, and then this skin is insert here, and the blood vessels are anastomosed in the neck. So by doing this, what happens is you are reducing the trismus to great extent. Otherwise, if you leave it raw, the patient will have severe trismus, and add to that post-operative radiation where it is going to fibrose and the patient is bound to have severe trismus and unable to have any good quality of life because of the lack of functions. We move on to the tongue. You can see the malignancy of the tongue on one side and hemiglossectomy, or with 1 centimeter margin, 1.5 centimeter margin being performed. Now, this is the kind of defect. Can you see the margins being given? So everywhere it's going to be more than a centimeters. And then it is going to be reconstructed. So this is how the radial forearm flap is being harvested. This is going to be the fasciocutaneous along with the cephalic vein and the radial artery over here and the vena comitans. Now, once this is harvested, we detach it from the base, and we carry the entire thing over there, and flap is insert. This is just to show the joining of the blood vessels. Like this is similar to the anastomosis in the myocardial infarction or MI, or wherever there is a heart blockade, to overcome that block, they harvest a blood vessel either from the leg or internal memory, and then they bypass the defect. It is the same procedure involved here. We join the blood vessels. Here it is being joined to the internal jugular vein. Can you see it over here? I'll show you the anastomosis later on, and the artery. Now, this is the same patient after the hemiglossectomy being reconstructed with a radial forearm flap, post-operative picture, because over a period of time, the skin becomes mucosalized and it almost resembles the native tongue. And I'll show you the video of the reconstructed tongue. How do they? Yeah. Speech is rehabilitated. Why it is very important? Yeah, it's over here.
It's a good day talking. My Gopal, yeah, I'm 56 years old. I'm staying care from Ramuti Nagar. Okay. Last May 3rd, I got operation. Yeah, it's almost a year now. Yeah, next month is going to be one year.
Look at the
Now,
clarity
as
of the
the
speech with
doctor
the tongue being
advised,
reconstructed.
I have to do the PET scan. I'm feeling okay and eating, opening the mouth. Little problem. Every day I'm doing exercise with the as per doctor's advice, using the ice cream sticks. Yeah. And yeah, I'm getting improvement. Yeah, that's what I can say.
How is the swallowing?
Swallowing absolutely no problem.
How much of the speech has come back?
Yeah, almost 90% I can speak, there's no problem.
Pronunciation, others will be able to understand?
Definitely. Pronunciation only, R, that is the only letter I can, otherwise I can talk and I can sing and, there's no problem.
Okay.
And I already discussed with the doctor about my shoulder, he advised me to do to join in the gym, and do some.
Yeah, so that's how the clarity of the speech is there. That's how, yeah, we'll show you the tongue mobility also.
Can you turn a little side? Yes.
You can see the tongue has been reconstructed. It is mucosalized. We are unable to make out which part is normal and which part is reconstructed. Okay.
On this side, your tongue.
Yeah. So
Yeah, here.
that is the amount of mobility that we get.
Okay. Take it inside, touch.
Yeah. So this is the other patient. This is 1 month post-op.
आपका उम्र
50 साल।
ओके, कहाँ से आ रहे हो?
और मैं बेंगलुरु आंध्र प्रदेश से आया।
ओके, क्या प्रॉब्लम था आपको पहले?
तो मेरे को जिप में अल्सर है।
हाँ,
तो जिम में
ओके, ज्वाइन कर रहे हो अभी?
जॉब भी।
Yeah. So can you see that reconstructed tongue? You can see the mobility.
कीजिए।
Yeah.
सिर्फ जीभ को। जीभ ऊपर कीजिए।
Yeah, that's fine.
हाँ।
So that is the.
Thank you.
That is the kind of quality of the reconstruction that we get with free microvascular flaps. So that is the recent trend. We have been doing this since last 15 years or something. Yeah, I'll take a minute to tongue. Now, right. Now, next. Okay. Now, what else are the developments? Now, the 3D printing has come in a big way. 3D printed models in the revascularized bone reconstruction of the mandible. I'll take you through a few of the things. Now, earlier, what used to happen is conventional thinking. Whenever you remove a bone, it has to be exactly matched. Now, wait for the resected specimen after the harvesting of the flap to calculate or measure the exact length and the shape of the flap. Not sure about the length and angulations. So what we are doing is get a CT scan, send it to a 3D printing company. This is also known as stereolithography model. Get these models printed. Now you know the defect already. Now, so the reconstruction team doesn't have to really wait for you to resect and get the specimen out. You already have marked, and then you can shape your fibula or scapula or the iliac before even the primary surgeon removes the primary tumor. So this is, you can match exactly the shape and size and the length of the angulations also of the mandible or the maxilla. And then, so this is how one of the patients' mandible is being removed, hemimandibulectomy, and then fibula reconstruction is done, the rehabilitation is done. Nearly normal, okay? So this is immediately after 6 months or a year. So the swelling will, over a period of time, will reduce, and this is the rehabilitation being done. So this is the other way where a big tumor with the skin involvement is being removed. On the right-hand side, we used to shown you how we used to manage before the 3D printed technology came in. We used to take a malleable metallic strip, measure it, and then nowadays what we do is we harvest the fibula. Can you see the shaped mandible and along with the 3D printed mandible? So we exactly match, we calculate, we check, cross-check so that the differences are minimized. And then we go and insert there and anastomose. So we get very good results with the, especially with the bone. The 3D printing technology has helped to a great extent. Now, what other advancement is made is that we also get the fibula guide. We have a virtual planning and the physical planning as well. These fibula cutting guides can be used to get that exact size as well as the angulations right. So this is being used over here on the fibula to cut the mandible. Now, this is the same patient with a PET scan and post-operatively how it looked. Okay. And the same patient after the reconstruction and then the rehabilitation down the year, 1 year down the line. Now, another example where the subtotal mandibulectomy is being done, you can see angle-to-angle resection over here, the primary tumor over there. And then this is how the fibula is being shaped. Into 3 osteotomies are being done and the angle-to-angle mandible is reconstructed. This is post-radiation 1 year or 4-year follow-up. The mandible has been restored to near normalcy. And this is absolutely no changes in the appearance as well as the functionality. And the patient can be rehabilitated with the dental implants as well. That's where all of us can play a big role in rehabilitating these patients. So this is another example why the competency also matters. Is complex defects like this is the involvement of bone, the lip mucosa and the skin. This is after the resection, the mandible, segmental mandible, the lip mucosa, as well as the part of the lip and the skin. This is the defect, that complex defect what we have, and is being reconstructed with the microvascular fibula along with the soft tissue. So this is how the lip competency is being maintained. So why different functions of the oral cavity are important in the beginning, I told you, because you will have to re-establish and rehabilitate all of them. This is the case of maxilla. This is a maxillectomy defect, that is the orbital floor, and the entire palate and the maxilla is being removed. This is 1 week post-op and 1 year follow-up, reconstructed with the microvascular fibula. One of the fibula segment, this is post-operatively, you can see near normal appearance except some enophthalmos on the right side. But had we not reconstructed that orbital support, it would have been worse. This is how post-operative CT scan shows the upper strut of the fibula that is gone and supported the eyeball. You can also use the mesh over there. And then another part is being supported by the support given to the alveolar area, and the vessel drops down and is anastomosed there. So this is how the maxilla also can be reconstructed. And the same way, what we have done here is, it is possible in the recent last year, we had a second wave of COVID and a lot of people suffered with the mucormycosis, where maxillas, and most of the times the maxilla and sometimes the mandible is also being excised. All these patients need not lose hope. They can be reconstructed well wherever it is feasible with a bony or soft tissue, and they can be rehabilitated as well. So this is one of the patients where she underwent a maxillectomy for the tumor of the maxilla. You can see the tumor there. And then after the maxillectomy neck dissection, it is reconstructed primarily with the microvascular fibula. And this is the post-op, immediate post-op, post-radiation one. So this is, it healed after a year or something, extremely well healed. And then the patient wanted the rehabilitation to be done. And again, the 3D printing came in very handy. We got the 3D printed models done. We can plan where the implants are going to be placed. This is the planning with the prosthetic background. And then the implants are being placed over here. And this is how the post-operative, post-surgery rehabilitation has taken place. So it is not enough to remove the cancer. It is not enough to reconstruct them. It is equally important for every one of us where we can be big partners to rehabilitate them so that they can come back to the normal life, go back into the society, and have an extremely good quality of life as long as they live. Good speech, good swallowing, good eating habits, and good aesthetics, and socially acceptable. So this is what we are. We have to take the social responsibility and then rehabilitate these patients as well. Now the question arises, can these defects be reconstructed? Yes. It is not possible that all the centers have a microvascular facility. It is not possible that all the patients will get a reconstruction, primary microvascular reconstruction immediately, because it is not possible to have the competency, and there are centers which are limited and the resources are also limited, where they would have done an excellent job in removing the primary tumor. Patients would have survived, and then they come back at a later date for the secondary reconstruction. Is it feasible? Yes, it is feasible. Primary reconstruction is always preferred, but sometimes it is not feasible. In these cases, the secondary reconstruction can also be done. You can see a patient with a maxillectomy defect, lost his job because of the non-presentable face. And this is the CT scan. We got the 3D printed model. And then we reconstructed him with the 3D print, the fibula, microvascular flap. You can see the being reconstructed, the eye support, and then under for the alveolus, and the vessel drops down, and then it is anastomosed. You can see the hair growth. The palate is completely being obturated. And this is the pre-op and post-op defect. Presentable, acceptable by the society. Okay. And then I'll show you the video of the anastomosis. In this case, what we do is, after the free flap, we take out those artery and vein. I'll show you only one of the videos where it is done under the magnification. This is done either under the magnification with a loop or under the microscope. The thread is being used either is a nylon or a proline. Depending on the vessel size, it is either 8-0, 9-0, or 10-0. And we anastomose. It is like suturing two tubes, okay, on 360 degrees. Now, this is sutured on one side, and we flip it over. You can see the IJV here, and it is common facial. This is being sutured here. And once we flip, you can see we are not bitten the other side wall. Now, this side wall will be sutured. Okay. So this is how little patience it will be. Yeah, you can see the needle size is around 4 to 5, 6 millimeters. And what is being used is a 9-0, I think, sutures. No, that is a vascular clamp it is calibrated not to injure the vessel wall and also to block blood flow. So, and then we take bites, either continuous or interrupted. We irrigated with the heparin saline so that the blood doesn't come out. Okay. Now, once the suturing is done, here is the video. We open up the clamps. You can see the blood flowing through. Okay. Yeah. Can we go back a little? Yeah. I'll show you once again. Yeah. Now the clamp is being released. You can observe how the blood flows. Yeah. So that's how the blood flows. So in any microvascular flap, we need one artery to be anastomosed that carries the oxygen to the flap. These are usually joined in the neck, either the facial or the lingual or the superior thyroid or any of the branches of the external carotid. And the veins are also joined to the any of the branches of the internal carotid, internal jugular or the anterior jugular. So the blood flow circulation is complete. Now, this is how the treatment completes. We have spoken about the management of the primary tumor, the neck, distant mets, no curative treatment. We have spoken about the management of the defect with the reconstruction, with the microvascular. Recent trend is a microvascular reconstruction. And then we've seen how to rehabilitate, where we can be participants. And then once it is done, the patient has to go for the radiation. Now, the radiation can be adjuvant radiation, usually starts 3 to 4 weeks after the surgery. Around 60 to 70 days is given, 5 days a week for 6 to 7 weeks. Now, the question arises, where is the dentist's role over here? Oral prophylaxis has to be done 2 to 3 weeks before the planned radiation. That is extraction of the teeth with poor prognosis. You do the oral prophylaxis also. Fluoride application has to be done to prevent the radiation-induced caries, and the salivary substitutes to manage the dry mouth and mucositis post-radiation. Now, what is the role of chemotherapy? It is not used alone for the curative modality. It is used as neoadjuvant, that is before the surgery, to reduce the tumor size in case of bulky tumors. Adjuvant after the surgery, along with the radiation for the close or positive margins or the extranodal spread in the neck or in the advanced nodes, which are very big in size. So that chemotherapy is also added as an additional treatment. Now, if the patient has received chemotherapy, when should we do the dental treatment? Any surgical treatment that involves bleeding should be done 3 weeks post chemotherapy. And before any surgical procedures, kindly get complete blood count, PT-INR prior to the procedure to rule out any bone marrow suppression. If the counts are less, you can postpone the treatment. Now, again, the role of us as a dentist is very important. Patient has to be on follow-up once in every 2 to 3 months in the first 2 years, and once in 6 months for the next 3 years, and annually thereafter. It is very, very important for the patient to follow up and for us to also to look into the patients for any recurrences or second primaries. If you can diagnose the recurrences and the second primary at a very early stage, then you are doing a great service to that individual and for the society as well, to reduce the burden of the big tumors and the big surgeries. Now, what is going to be the future? Artificial intelligence driven early diagnosis and management is going to be the future. It's already coming in a big way because of mobiles and so many apps. The tumors or the pre-malignant lesions getting converted into the tumors can be diagnosed at a very early stage. And the management also can involve a lot of artificial intelligence, which is being tried now. And it's going to be more of a molecular level therapies. And maybe over a period of time, the tissue engineering or a 3D printed tissue engineering, the way you replace the car door or something, your car with another door, you can replace probably the mandible with another mandible, which is exactly matching your native mandible. And that can be done. That could be the future. And thank you for the patient listening. I'll be taking up questions. And thank you, D.Y. Patil Dental School, Pune, IDA. Special thanks to Dr. Anand Shigli, Dean, and my dear senior, Professor Dr. Vikram and Prachi and Oral Surgery Department. Thank you so much. Any questions? I'm open for that.
We can unmute the audios for the students. If they have any questions, they can address it to sir.
Yeah, are there any questions? So this is because it is difficult to cover entire thing. Since the way of the other dentists and very few of them are into the maxillofacial surgery. So you should know our role, your role where in the early diagnosis, and you should have a fair idea about the overall management. And we should also know the where we stand in the rehabilitation, that is a dental rehabilitation, as well as the prevention of the radiation caries. And because all of them, these patients who would have received surgery and radiation, they would definitely come for some of the dental treatments. And we should know when to treat post-radiation, when not to do extractions post-radiation, and if they have received chemotherapy, wait for 3 weeks, get the blood investigations done, and then start the treatment.
Thank you, Dr. Satyajit, for your excellent presentation.
Thank you, sir.
And I would like to know,
Not audible.
hello.
Yes, I can hear now.
Thank you, Dr. Satyajit, for the excellent cases that you displayed, the array of treatment modes that you showed us. Really, it was an excellent and very informative session, I should say. I would like to know, before your fibulary 3D planning, can these implants be placed well in advance so that when you reposition the fibulary graft with microvascular, can these osseointegrated implants be brought into the functional loading?
You can place the implant at the time of primary reconstruction. That option is always open. But you should also keep it in mind where the background in which we are working. Why I'm telling you is, although it is not my part, because implants involve a lot of cost. And in case the fibula fails, along with that, the implants also fail. So you have to be more careful. And the second thing is that the planning, if you are planning to place the implant, and if you are quite sure about the survival, and we are doing it now, the planning has to be very well, because even a couple of millimeters of the change in the orientation of those implants will make the prosthodontist's life difficult for them to rehabilitate post-operatively. So once you place, the orientation of the fibula has to be exactly in the prosthetic arena or area where it can be rehabilitated easily. Yes, it can be done.
Are there any more questions? Satyajit sir, I thank you for the excellent presentation. The kind of cases that you have shown us were really very enlightening, and the very good graphics. And we are very pleased that you came and you delivered us this lecture on such an important day today, sir. And also, I would like to thank our Dean sir for giving us this opportunity for this presentation today, and for inviting Dr. Satyajit Dandgi sir today with us at DYPDS. Thank you so much, sir.
Thank you, Professor Shigli. We only call him because he is my senior now. And thank you for the invitation.
Thank you, Satyajit. Thank you so much. Thanks a lot for coming in and enlightening us with your knowledge. Thank you so much.
My pleasure.
Yeah, hope to see you soon live. Okay, we wanted to call you we wanted to keep it offline only, but because of all these COVID things and all, like, so next time surely then we'll come up with something different.
Oh yes, by all means, sir. Hopefully this pandemic goes down and we'll all meet again.
Sure.
Thank
you so much.
Bye bye, Vikram. Bye bye.
Thank you, sir.
Thank you so much.
Sure. Thank you, Vishwanath.